Hi all, this is Scott. Welcome back again to the Neuro Knowledge Podcast. This episode will be focusing on multiple sclerosis. As mentioned earlier in the week on the Facebook page, the podcast will be moving to a release date of Fridays as opposed to Wednesdays when it was being released previously. We will stick with 2 episodes a month, however. The podcast, as always, is available at iTunes, Google Play, Spotify, and on our Facebook page. You're able to subscribe and rate the podcast at any of those outlets as well. With that, let's jump into today's episode on multiple sclerosis. Multiple sclerosis, or MS, is a chronic inflammatory condition which affects the central nervous system, either the brain or the spinal cord. In MS, the main target of the immune system is a tissue called myelin. Myelin forms a sheath around the surface of a nerve axon. That's the part of a neuron or nerve which conducts a signal along its path. The myelin sheath, when functioning properly, serves to protect and stabilize the axon, as well as promotes the rapid conduction of a signal along the axon. In addition to myelin, cells within the central nervous system called oligodendrocytes are also targeted. Oligodendrocytes are the cells which actually produce the myelin protein and aid in its organization around the axons. When the immune system creates an inflammatory response against myelin within the central nervous system, the tissue is slowly lost from around the axons. This can result in slowing of the conduction of a signal along an axon and possibly damage to the axon itself. This loss of myelin can lead to a wide range of potential symptoms depending on where it occurs in the central nervous system. In MS, attacks affecting different areas of the central nervous system can lead to an acute change in neurologic function. Attacks of acute loss of vision due to inflammation of the optic nerve, called optic neuritis, is one possibility. Additionally, reduction of limb strength, sensory loss, cognitive dysfunction, or altered coordination are other symptoms that can develop. Over time, the accumulation of different lesions in different areas of the central nervous system can lead to chronic symptoms, including bowel and bladder dysfunction, spasticity in the limbs, and fatigue. I think it's important to address a misconception here regarding fatigue and its relationship to multiple sclerosis. While fatigue is quite common amongst people with a diagnosis of MS, and usually with a diagnosis of MS for several years, it's important to point out that there are a large number of other causes of fatigue which could be at play. I think a neurologist often receive questions about whether fatigue, perhaps with other symptoms, or just fatigue itself could be related to MS. In the majority of cases, it is not. There's another explanation for someone's fatigue. Unless someone has had one or more attacks of the symptoms we listed, there is likely another explanation for someone's fatigue besides multiple sclerosis. Now, when we discuss MS, there are different potential classifications based on a person's clinical history and imaging findings. An individual can move from one classification to another based on their course over time. I think it's important to define and distinguish these different classifications before we go on. Radiologically isolated syndrome, or RIS, is a classification where someone may have one or more lesions or plaques on MRI which are consistent with MS. However, they've never had a clinical event with the neurologic deficits we discussed previously. In clinically isolated syndrome, the reverse is true. Clinically isolated syndrome, or CIS, is a classification where a person has had a single clinical event, such as, say, optic neuritis or a sensory deficit or numbness, which lasts at least 24 hours and then resolves either completely or partially. The attack can be monofocal, affecting just one site in the nervous system, such as optic neuritis in the right eye, or the attack can be multifocal, affecting multiple sites in the central nervous system with different symptoms. For example, perhaps left eye optic neuritis and right arm numbness. These individuals have not had a second clinical attack, however. Typically, these symptoms will lead to neuroimaging of some type with an MRI of the brain and/or spinal cord, depending on the symptoms. Patients with a high risk of developing MS are those with clinically isolated syndrome and MRI-detected brain lesions that are consistent with those seen in MS. Someone with a clinical event as well as MRI lesions consistent with MS has approximately a 60 to 80% chance of a second neurologic event and a diagnosis of MS within several years. Those with a low risk of developing MS have had a clinical event, however, there's not really much in the way of MRI-detected brain lesions, and so this person has about a 20% chance of developing MS over the same time period. Relapsing remitting MS is the most common classification of multiple sclerosis when diagnosed and represents approximately 80 to 85% of all cases. People with relapsing remitting MS will have a number of classical MS attacks or exacerbations consisting of a range of potential symptoms with either full or partial recovery between them. There is no disease progression between the episodes. Symptoms a person can experience during an acute attack are fairly wide-ranging, like we discussed previously. optic neuritis or inflammation of the optic nerves resulting in decreased vision, transverse myelitis, which is an inflammatory lesion in the spinal cord, with often disturbances in sensation and potentially weakness below the level at which it occurs, incoordination or weakness of a limb, amongst other potential symptoms. During these clinical attacks, imaging, including MRI of the brain and spinal cord, show evidence of an active MS lesion in an area which would explain their symptoms. An active or acute MS lesion is characterized by enhancement on specific MRI sequences performed with contrast given via IV. Now, there are specific criteria on imaging and clinical history which need to be met in order for a diagnosis of relapsing remitting MS to be made, and we'll discuss these a little bit later. Secondary progressive MS evolves from a relapsing remitting course to a more progressive decline in neurologic function. During this progressive phase, a person can additionally suffer acute exacerbations or relapses, but these are typically less frequent and in certain patients don't occur at all. Typically, someone with a prior relapsing remitting MS diagnosis in, say, their late 20s or early 30s can potentially convert to a secondary progressive course in their mid to late 40s or early 50s. Someone can convert to secondary progressive MS at any time during their course, however. The majority of patients with a diagnosis of relapsing remitting MS convert to a progressive course at some point. However, their symptoms and degree of disability can vary quite widely. I think it's important to address another misconception regarding secondary progressive MS. There are often questions about the degree of disability one will have given a diagnosis of secondary progressive MS, or maybe perhaps even a new diagnosis of relapsing remitting MS. Specifically, people often feel that there's an inevitable course which will lead to one either being wheelchair dependent or worse. In fact, approximately 2/3 of patients with MS and secondary progressive MS will remain ambulatory. However, typically a gait aid such as a cane or walker may be needed. Now, there is a fairly wide range of disability that can be seen in secondary progressive MS, and it is somewhat difficult to predict exactly what degree of disability someone will develop over time. However, I would say that those who remain active and continue to ambulate with either a walker or other gait aid generally preserve their functional ability in that realm much more so than those who rely on either a wheelchair or an electric scooter or some sort of similar device early on in their disease course. Intensive physical therapy in this setting is also quite beneficial in order to preserve someone's ability to ambulate independently. Finally, primary progressive MS is characterized by a gradual but steady progression of disability from the onset of symptoms, with really few or really minimal exacerbations or remissions along the way. This can lead to marked accumulation of disability over time, as it is notoriously difficult to treat and control. Fortunately, it represents only about 15% of all MS cases when they're diagnosed. Now that we've discussed those, in the episode description there are links to some helpful diagrams for relapsing remitting MS, secondary progressive MS, and primary progressive MS to get a better idea of what the disease course looks like over time. I think an important additional concept to touch on briefly is that of active and inactive disease. Active disease refers to a situation where a person with MS develops new, enhancing lesions on MRI, either with or without clinical symptoms. This may lead to changes in treatment depending on the situation and overall clinical course. Inactive disease is used to describe a person with MS with stable MRI findings, no evidence of an exacerbation on history, and a stable physical exam. This can be the case in someone with relapsing remitting MS between exacerbations, or someone at the end of their disease course with really no changes over the course of several surveillance MRIs. When discussing multiple sclerosis, the number of cases of MS varies really quite widely based on geographic location. The areas with the highest rates of MS include pretty much all of Europe, southern Canada, the northern United States, New Zealand, and Southeast Australia. In these locations, there are approximately 60 to 100 cases of MS per 100,000 people. There is also a fairly high female to male ratio of approximately 2 to 3 female cases for every male case, and this ratio has increased really over the last 25 years or so. Interestingly, MS is also the second leading cause of disability related to the central nervous system amongst young people, next to trauma. In terms of risk factors for developing MS, there does seem to be a genetic component. However, it is not directly inherited. There seems to be some combination of a multitude of genes that can increase someone's risk for developing multiple sclerosis. There are also a number of environmental factors such as low vitamin D and cigarette smoking that have been shown to increase the risk of MS. And so how exactly is multiple sclerosis diagnosed? Well, there have been a number of different changes to criteria over the years, but I think the main point to distinguish here is something called a separation in space and a separation in time. To diagnose MS, a doctor needs to fulfill criteria which shows insults to the central nervous system separated by both space, meaning different locations, and time, meaning lesions that have occurred in the past as well as lesions that have occurred more recently. A doctor must find evidence of damage in at least two separate areas of the central nervous system, which includes the brain, spinal cord, and optic nerves, and find evidence that damage occurred at different points in time. Additionally, we must also rule out other possible diagnoses which can mimic MS in certain patients. There are a number of different tools and tests that need to be performed in order to make a diagnosis of MS. As always, a careful clinical history and neurologic exam is of utmost importance. The history focuses on events concerning for an MS attack, especially in those who do not have a known diagnosis of MS. Symptoms can obviously vary quite widely, and it's really key to try to pin these down as best as possible. A doctor may ask about episodes of painful loss of vision, and typically a blurring of vision, which comes on over several days and lasts for weeks, slowly improving on its own in most cases. This history, particularly the painful aspect of vision loss, is typical for optic neuritis or inflammation of the optic nerves often seen in MS. Questioning about episodes of double vision is also fairly common. A doctor will also commonly ask about episodes of numbness and tingling, particularly that which ascends and is present across a particular level of the torso. This history is consistent with somebody who has had an attack of transverse myelitis. This is an area of inflammation in the spinal cord which can cause numbness, tingling, weakness below the level where it occurs. Additionally, a physician may ask about episodes of weakness of a limb, numbness affecting a limb, or incoordination of a limb. An important tool in the diagnosis of MS is obviously an MRI of the brain and the spinal cord. On imaging, doctors are looking for lesions typical of MS, and these are areas of inflammation affecting the optic nerves or the white matter of the brain and spinal cord. The white matter is a highly myelinated tissue either within the brain or the spinal cord. In the brain, lesions are commonly near a particular area of the brain called the corpus callosum. This is a white matter tract which connects the two halves or hemispheres of the brain. Additionally, lesions are commonly seen along the ventricles, near the surface of the brain and in the brain stem. Lesions are typically bright on T2 or flare sequences on an MRI. An acute lesion is one which enhances or is bright on an MRI when contrast is given by IV. The presence of lesions on MRI which enhance and other lesions on the MRI which do not enhance demonstrates that there has been an insult to the central nervous system on at least two separate occasions. This allows doctors to fulfill that criteria about separation in time. Now, MRI imaging of the spinal cord is quite similar to the brain, and again, bright T2 or enhancing lesions in the periphery of the spinal cord are commonly seen. In MS, short segments of the spinal cord are affected, which can lead to areas of inflammation really not causing many symptoms. However, as lesions accumulate or there are larger lesions that develop, the potential for symptoms and disability increases. A fairly typical element of the workup for a potential diagnosis of MS is an ophthalmologic exam. An ophthalmologic exam is important, especially in those with primarily visual symptoms, such as optic neuritis. Typically, visual acuity along with color vision are very closely tested. Additionally, dilating the pupil and performing a thorough exam of the retina allows doctors to visualize the optic disc, which is the end of the optic nerve that can be seen in the back of the eye. In acute optic neuritis, the disc is typically swollen due to the inflammation occurring along the nerve course. In those with prior attacks of optic neuritis, the disc may actually show signs of atrophy or shrinking. This can be closely monitored over time by a trained neuro-ophthalmologist. Additional testing typically involves testing the spinal fluid. Spinal fluid is tested via a lumbar puncture or spinal tap. In the spinal fluid, patients with MS typically have an increased IgG index and the presence of what are called CSF oligoclonal bands. Both of these are markers which are aimed at identifying the increased production of antibodies and inflammation within the central nervous system. Typically, when trying to establish a diagnosis of MS, additional testing to rule out conditions which can mimic multiple sclerosis are also pursued. Particularly if there's an atypical presentation, there's a broad range of testing which can include infectious and other inflammatory conditions such as NMO spectrum disorder, which will be the focus of a future podcast. Now, at this point, I think we can discuss the treatment of multiple sclerosis. I think it's important to break down treatment into two separate scenarios, that being of an acute MS attack or MS exacerbation, and more chronic maintenance therapy, which is often referred to as disease-modifying therapy. In an acute attack, there are two main treatments available: high-dose steroids and plasma exchange, or PLEX. When someone presents with an acute attack such as optic neuritis or transverse myelitis, high-dose IV steroids are typically the very first-line treatment. Typically 1,000 milligrams of a steroid called methylprednisolone is given daily for 5 days. Now, there is an option for high-dose oral steroid treatment, typically prednisone 1,250 milligrams daily if a person's attack is not optic neuritis. This has the drawback of a large number of tablets, but the benefit of being able to administer doses easily at home as opposed to going to an infusion center. A steroid taper can be used after the initial high-dose burst, but is not typically required. Steroid treatment is important as it reduces the risk of further worsening or not improving within 5 weeks compared to no treatment at all. Now, depending on the area of the central nervous system involved and the resultant deficit, this may occur in a hospital setting or as an outpatient. If someone has an acute MS attack and does not respond to steroid treatment, plasma exchange or PLEX is a secondary option. PLEX usually requires the placement of a central line. This is an intravenous line, usually into the jugular vein in the neck or the subclavian vein under the collarbone. In a plasma exchange session, a person's blood is removed through the central line. The plasma portion of the blood is filtered, removing antibodies which may be at play in an MS attack, and donor plasma is then used to replace the patient's plasma. 7 sessions occurring every other day is the usual plasma exchange protocol during an acute MS exacerbation. Research has shown that plasma exchange is beneficial in MS attacks and may lead to stabilization and faster improvement than no treatment. Now, the second arm of MS treatment is a maintenance or disease-modifying therapy. Now, really, the goal of this therapy is to reduce the risk of an MS attack as well as progression on an MRI. Disease-modifying therapy are treatments which are taken regularly in hopes of reducing the risk of an MS relapse by modifying the immune system. They are also called immunomodulatory treatments for that reason. I think the best way to think of these medications is in 2 different groups or tiers. Tier 1 would include medications which are often tried first for someone who's had perhaps 1 or 2 MS attacks and has typically not tried a disease-modifying treatment before. Tier 2 consists of medications which are escalated to in those who have MS refractory to therapies in Tier 1. This means that despite trying 1 or 2 different medications in Tier 1, someone is still suffering MS relapses or exacerbations. Tier 2 medications often have the potential for very severe side effects, and so for that reason are usually not used as first-line therapy in most cases. There are certain exceptions, however. As always, a close and ongoing relationship with one's neurologist is really important in order to discuss treatment side effects and effectiveness. Additionally, changes in treatment and options for doing so need to be thoroughly discussed on an ongoing basis. Now, when we discuss the different tiers, Tier 1 medications include interferon-based medications, glatiramer acetate, dimethyl fumarate, and teriflunomide. We'll start with interferons as they're fairly commonly the first-line therapies used. Interferons were the very first approved medications for the treatment of MS, with the first formulation approved back in 1993. They have been shown to reduce the rate of relapses and reduce disability compared to placebos. There are a number of different interferon formulations available, which require dosing ranging from every other day to every other week. The interferons are either injected under the skin, a so-called subcutaneous injection, or into the muscle based on the different formulation. The exact mechanism by which interferons work is not entirely known, but it is believed that they include stabilization of the blood-brain barrier, which limits the ability of inflammatory cells to enter the central nervous system. It is believed that it also shifts the immune system to a more anti-inflammatory milieu overall. The main side effects include post-injection flu-like symptoms, which can be severe and limit its use, and injection site reactions and rashes. The second option is also an injectable medication and is called glatiramer acetate. It has a long history of use in MS after its approval in 1996. It is injected just under the skin on either a daily basis or in a 3 times per week formulation. Again, the mechanism by which glatiramer acetate works is not entirely understood. The main side effects of the medication are again injection site reactions and allergic reactions. While glatiramer acetate is generally better tolerated than interferons from a side effect standpoint, it has largely fallen out of favor amongst MS specialists from an efficacy standpoint. The next potential option in Tier 1 is a medication called dimethyl fumarate. This is an oral medication and is taken twice a day, which has been used for a number of decades to actually treat psoriasis outside of multiple sclerosis. It is believed that the medication has anti-inflammatory and neuroprotective effects based on its effect on cell pathways. Typically, side effects include flushing, which can improve with a daily aspirin, GI upset with diarrhea and nausea, as well as decreased lymphocyte levels in the blood. And the final medication in Tier 1 is a medication called teriflunomide. This is an oral disease-modifying therapy, again taken on a daily basis. It inhibits an enzyme which is critical for the production of certain components of DNA in rapidly dividing cells. This leads to a reduced proliferation of autoreactive T and B cells in the immune system, thereby hopefully limiting the amount of inflammation in the central nervous system. Its main side effects include elevated liver enzyme levels, infection, hair thinning, and diarrhea. Now, an important point to discuss with the medication, however, is its potential to cause birth defects. This risk is so high, in fact, that if it is prescribed to women of childbearing age, effective contraception is a necessity. Additionally, there is a fairly prolonged washout period required after stopping the medication. This means that once the medication is stopped, it does remain in the body for a prolonged period of time, and its ability to cause birth defects remains as well. There is an accelerated elimination protocol which relies on activated charcoal or a drug called cholestyramine to bind the drug and help reduce its level in the body at a faster rate. However, patients often have quite a difficult time tolerating these medications. Now, let's say that somebody has been on either one or two of the Tier 1 medications for some time and they've developed multiple MS exacerbations over that time period. At that point, a physician may discuss with a patient about escalating therapy up to one of the Tier 2 medications in hopes of bringing the MS under better control. When discussing Tier 2 medications, the oral therapy available is a medication called fingolimod. This was the first approved oral therapy for the treatment of MS, and it is a pill taken once daily. It inhibits the function of sphingosine 1-phosphate. This works to keep lymphocytes within the lymph nodes as opposed to circulating in the bloodstream. This obviously limits their ability to reach the central nervous system and cause inflammation there, which could contribute to an MS attack. Important side effects to discuss are the potential for heart arrhythmias, particularly with the first dose of the medication. Typically, when starting therapy with fingolimod, a person is monitored for 6 hours or so following their first dose with serial EKGs to assess the heart rhythm and ensure that there is no major abnormality occurring. Additionally, the medication can cause macular edema, which can impair vision, increase liver enzymes, mild blood pressure increases, and increased risk of zoster reactivation. This latter point can be minimized by ensuring that a patient has received immunizations for varicella zoster virus with the Zostavax vaccine before beginning therapy. Now, the remainder of medications in Tier 2 are intravenous therapies, which are given fairly infrequently. A fairly common medication that can be escalated to is a medication called natalizumab. This is an intravenous therapy that is administered every 4 weeks. It is used in patients who continue to have frequent relapses despite prior treatments in Tier 1 or with fingolimod. Natalizumab binds the receptors on white blood cells and prevents them from leaving the bloodstream to enter the nearby tissue, including the central nervous system. This reduces the ability of elements of the immune system to create inflammation in the brain and the spinal cord. There is a fairly serious side effect associated with natalizumab, and that is the risk of a condition called progressive multifocal leukoencephalopathy, or PML. This is a potentially severe and life-threatening condition related to an underlying viral disease which can cause progressive inflammation of the white matter, particularly in the brain. The virus in question is called JC virus and is typically tested for before beginning treatment with natalizumab. The risk of PML is approximately 4 per 1,000 people. However, there is an increased risk with prior immunosuppression, prolonged use of natalizumab, or JC virus positivity. Typically, PML is treated by reducing immunosuppression, such as holding doses of natalizumab or other disease-modifying therapy, and monitoring with subsequent MRIs. When reducing immunosuppression, the risk for excessive inflammation around the areas affected with PML is a secondary complication of the condition. Another IV therapy available in Tier 2 is a medication called alemtuzumab. This is an IV therapy typically reserved for patients who have failed at least 1 or 2 first-line therapies with multiple relapses while on disease-modifying therapy. Alemtuzumab is a monoclonal antibody directed against CD52, a surface antigen present at high levels on T and B lymphocytes in the blood. Alemtuzumab rapidly depletes lymphocytes, producing a sustained depression in their levels for up to 1 year. It is dosed 2 times, usually 1 or 2 years apart depending on disease activity. Alemtuzumab has significant risks for infusion reactions, almost a 30% risk of secondary autoimmunity such as thyroid disease, and this can be fairly remote from the time of exposure, as well as a potential long-term risk for malignancy. Given this, they have a specific risk evaluation and mitigation strategy that should be undertaken before beginning the medication. Finally, ocrelizumab is an IV treatment used for both relapsing remitting MS as well as primary progressive MS. It is administered in 2 IV doses, 2 weeks apart, and the medication is typically redosed every 6 months. Ocrelizumab is an antibody to the CD20 antigen on the surface of B cells in the immune system. Antibody binding to CD20 results in removal of B cells from the circulation and limits their ability to produce antibodies in that setting. The main side effects are related to infusion reactions, which can be severe in certain patients. Additional side effects include the potential for hepatitis B reactivation and infections, including PML. There are additional immunosuppressive options that can be pursued in patients with severe, rapidly progressive disease or refractory disease to the above therapies. These include medications such as cyclophosphamide, rituximab, cladribine, and mitoxantrone. However, the latter has really largely fallen out of favor due to its marked side effect profile. Discussing and escalating to these therapies is really a discussion that is best had between a patient and their neurologist, and so we'll only just briefly mention them here. Now, given that MS involves inflammation of the central nervous system and insults to different areas of the brain and spinal cord over time, a variety of different symptoms can develop in patients. These include bladder and bowel dysfunction, depression, emotional changes, fatigue, which we discussed previously, pain, spasticity in the limbs, walking and gait difficulties, amongst a host of other symptoms. I don't think we need to delve into medications designed at targeting each of these symptoms. However, rest assured that there are a number of medications available in terms of treating and reducing the symptoms in this regard. Okay, I think that brings us to the end of another episode of the podcast. Hopefully you enjoyed this episode. It was on multiple sclerosis, and we discussed a variety of different aspects of the disease. We discussed some fairly common misconceptions surrounding a diagnosis of MS, and those include fatigue and its relationship to MS, as well as secondary progressive MS and the disability that can result from that. Additionally, we discussed a host of treatment options both for an acute attack as well as maintenance or disease-modifying therapy. And so just before we go, I'd just like to remind everyone again to rate and subscribe to the podcast. We're available on iTunes, Google Play, Spotify, and on the Facebook page. Thank you again for listening today, and I hope you're able to join me again in a couple weeks when we'll be discussing ALS, or Lou Gehrig's disease. Hope to see you then. Thanks again. Take care. The Neuroknowledge podcast is meant as an informational resource for patients and their families. It is not meant to diagnose or treat any medical condition. It is not meant as a replacement for medical evaluation. The views expressed in the podcast are solely those of the speakers and do not necessarily reflect those of Mayo Clinic or its subsidiaries.